So good afternoon to all of us, and thank you all and welcome everyone to our Research Connect series for today. My name is Cynthia Lamisi Anaba, a CDRTP trainee with the center, and I'll be facilitating today's session. First, I would like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for diverse indigenous peoples, including the Cree, Blackfoot, Métis, Nakota, Shuks, Iroquois, Dene, Ojibwe, Saltios, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I encourage all of us, if you wish to, you can write your land acknowledgement in the tag box, just as I have acknowledged exactly where we are hosting this program from. We would also like to acknowledge Takeda, AstraZeneca, and CIRH, without whose general support, we could not have hosted these sessions. So we surely appreciate their general support and kindness. Before we dive into the main content for the day, I would pass it over to Demetra for some general CDTRP updates.
Thank you, Cynthia.
So over to you, Demetra.
Thank you. I have one announcement for today. So it is our save the date for the annual scientific meeting. This year's ASM is going to be hosted in person and hybrid, but in person component in Montreal, Quebec on December 5th through 7th. The registration is now open and everyone can register online on our website. So I will attach a link in the chat box shortly. So that's all from me. Thank you.
Thanks so much for the announcement, Demetra. So before I introduce the speakers for today, of course, I still have a few housekeeping notes that I need to share with the House. Today's session is recorded and will be posted on CDRTP website and YouTube channels, just so that we all know. And during the presentation, of course, we are all reminded to keep our mics off or muted so that we can all follow the presentations and not interrupt. And if, of course, we have questions or comments, we can raise our hands with the raise hand button. I think it's beneath or below the page, or we can as well type it in the comment section so that at the end of the presentation, our presenter can answer our concerns or questions. On that note, I am pleased to introduce our presenter for today, who is in the person of Dr. Rohit Malyala. Dr. grew up in Ontario and completed his undergrad studies at the McMaster University in Health Sciences. There, he became interested in kidney transplants, working with different nephrologists in Toronto and Hamilton, studying kidney from both a wet and dry lab perspective. Of course, when Rohit came to UBC for undergrad medicine, he became exposed to the general side of kidney transplant. His first introduction to the staff urologist at UBC. Over the course of medical school, taking on different projects in endourology and transplant, he became convinced that a career in urology was right for him. And he will definitely share with us how that journey has been today. Subsequently, matching to UBC's highly competitive postgraduate residency training in urology in 2023. He is a self-taught computer programmer, machine learning, and biostatistics enthusiast, and outside work. He enjoys exploring beautiful BC, by motorcycle, staying active in the gym, and trying different cafes in Vancouver. We are very excited to welcome and, of course, give you the floor now and present for the day. So on this note, I introduce to the house Dr. Rohit Malyala, who will be the presenter for today's session. Dr. You're most welcome, and I hand over to you.
Thank you so much for the kind introduction. Hi, everybody. Yeah, my name is Rohit. Let me share my screen first, and then let me see. I hope this is working for everybody.
Perfect.
Excellent. Okay. Yeah, my name is Rohit. I'm a PGY1 in urology. I'm here today to present some work out of UBC's Department of Urology, supervised by Dr. Chris Guan. Dr. Guan unfortunately couldn't make it with us today because he's scrubbed into a transplant. But yeah, but we've been presenting this presentation at a couple of other places as well. And this time we have some updates that are more machine learning focused. Some overview on this project. Basically, like Dr. Guan is a kidney transplant surgeon and a urologist at VGH. And over the last several years, he's reflected a lot on how to improve transplant care. And overall, what we felt is that while a lot of attention is paid to preoperative optimization and postoperative management of kidney transplant patients, what happens in the OR is still a little bit of a black box. And we felt that there was room for improvement in that realm of transplant medicine. So our work is all about exploring something called goal-directed anesthesia for kidney transplants, and then determining what good hemodynamic targets are or good anesthesia targets are for transplant recipients intraoperatively, and whether that can affect the function, the early graft function of the kidney, newly transplanted kidney. And then the other thing is that anesthesia is pretty complex. So what we're really excited to showcase here is how we've amalgamated all the different data types and then use different complex statistical or machine learning strategies to glean insights from what is a very challenging but also very rich data source. So neither of us have any relevant disclosures, and just as Cynthia was saying earlier, we should recognize that we're living and working on the traditional and unceded territories of several First Nations communities, the ones listed above here for Vancouver, what we call Vancouver specifically, but yeah, just worth saying that again. So objectives for our presentation today. Briefly, we want to go over some current practices in goal-directed therapy for transplant anesthesia. And then from there, really delve into our research on a large data set of anesthesia records from a VGH-specific transplant recipient cohort. And then discuss some of our work in using machine learning in particular for analyzing these large and detailed anesthesia records. As everyone is aware, achieving and maintaining hemodynamic stability during and after surgery to ensure adequate perfusion and adequate flow to every organ is a goal of every anesthesiologist. And it's not just maintaining hemodynamic stability to keep someone alive in the OR, like intraoperatively, but it's also to ensure their good health moving forward, even outside the OR. And that's the goal that GDT seeks to help out with. So very broadly, when we refer to GDT, we're referring to all of the different monitoring techniques and all of the different approaches that are used to help guide anesthesiologists, and then also like what their options are with like actually administering treatment to patients to meet those targets. GDT spans a broad range of actual techniques, from like common things like using stroke volume variation or SPV guided fluid therapy, and then also even more like very specific measures of tissue perfusion that are less commonly used, like transcutaneous O2 measurement or tissue pH monitoring. And then as far as methods to improve oxygen delivery go, there's a variety of options that are used in the OR, and they're explored in the literature from fluids, inotropes, vasopressors. And then in our own work, we're going to be looking at all of these different interventions. Now, it's not exactly a foregone conclusion whether GDT practices are always useful in all circumstances. There's honestly a lot of heterogeneity in what constitutes GDT, so it's actually pretty hard to study systematically. Overall, however, I would say that large meta-analyses on this topic consistently demonstrate the utility of GDT, especially in certain subgroups like high-risk patients. And this image that you're looking at on the right is adapted from a fairly recent meta-analysis of studies looking into goal-directed fluid therapy and avoiding postoperative AKI incidents. And then overall, you can look at the diamond, the amalgamation of all these effects culminates in a demonstrated benefit for goal-directed fluid therapy on AKI post-op. So now that I brought up kidneys, this brings up the question of why do we want to go through the exercise of GDT and transplant in particular? Transplant's the treatment of choice, of course, for those suffering from end-stage renal disease, but the supply of donor organs far outstrips the demand. Sorry, the demand far outstrips the supply. So that's why one of the mandates of BC Transplant is one transplant for life. You want to get the most economy out of each and every donation. So one of our goals is to optimize for short and long-term outcomes of the kidneys we transplant. And like I was saying earlier at the beginning, there's a lot of research in optimizing donor and recipient characteristics pre-transplant, but there's a fairly large knowledge gap in optimizing for what we think is a pretty important part of the transplant process, which is the surgery itself. And it's a complex operation, so there's certainly room to gain more utility and longevity from each graft by improving what happens in the OR specifically. Transplant is also just only becoming more and more common. And in Vancouver, we're one of the largest transplant programs on the continent by volume of transplants and then also by research productivity. So we have the opportunity to gain good insights by improving kidney transplant care that other lower volume sites can't necessarily approach. And we can leverage the learnings that we have from our enormous clinical volume. In particular, as of late, we've been using more and more DCD kidneys, and that's a pattern you'll see at every transplant center. That is, to be specific, donation after cardiac death or circulatory death kidneys. And that's been a great step forward in improving the accessibility of transplant to patients. But DCD kidneys, as you guys know, have a higher rate of DGF or delayed graft function. And we've defined that as when the recipient needs dialysis within 7 days of what was otherwise a technically successful surgery. Now, DGF on its own is a poor outcome because it's tough on the patient and it's quite costly to the healthcare system too. And then there's also evidence to suggest that experiencing DGF early on has implications down the line for long-term graft health. What we have here is a graph from the collaborative transplant study. And what we see is that the transplants with DGF in blue do worse from the baseline in green for 5-year graft survival. And then if you have DGF and acute rejection early on, those kidneys have even worse survival. So DGF is one of our main outcomes of interest. This is where anesthesia comes in. You have these vulnerable donor organs. They've been disconnected from a donor blood supply for a number of hours at least, unless it's a live donation. And so it seems almost self-evident that getting the early blood supply right after vascular anastomosis just right is important. And overall, this is part of a larger theme in anesthesiology research that brings the scope out of anesthesia out from what happens just in the hospital, just in the OR, to what happens to the patient in the long term. The majority of data in the space is from retrospective data with pretty rare, small prospective trials. On review of the literature, many of these retrospective studies look at heterogeneous data sets and they look at different physiologic targets, and then they express their recommendations for GDT rather differently. For example, in this paper from Thomas et al., which is perioperative, it's in orange, perioperative blood pressure control, DGF, and acute rejection after transplantation. They make a recommendation to maintain the systolic blood pressure above 120 on the basis that 50% of the patients with an SBP below that experience DGF. And then in a 2019 paper from Kaufman et al., that's the one in green, they expressed that a MAP below 80 increases DGF by 2.5-fold. So there has been exploration in the past on GDT in transplant. There's also small prospective trials for GDT and transplant. This is an example of one recent work in the space from Cavalieri et al. This is called Perioperative Goal-Directed Therapy During Kidney Transplant, Impact on Major Postoperative Complications. And here what they did was they compared a stroke volume optimization protocol using a flow track sensor versus just conventional CVP and MAP targets. And what they noted was that the GDT group experienced significantly lower DGF than the conventional fluid therapy group. The difference was in the range of like 4 out of 33 people versus 11 out of 33 people getting DGF in the conventional therapy group. And then they also plotted out a cool comparison of the average amounts of fluids used at each point throughout the surgeries. And we can note that the stroke volume optimization group were on average receiving more fluids early in surgery, but then less around the time of the anastomosis. So with the understanding of what the literature in the space of GDT and anesthesia looks like, we want to get into our work looking at transplant recipients' outcomes at VGH. Recently, VGH moved to something called CST. They finally made our paper records all electronic, so now we use Cerner. But if you worked at VGH, you'll have seen these paper anesthesia charts, these records. Over the last number of years, we've been collecting these records for every transplant recipient and then digitizing them and then combining them with a pre-existing reference database for pre-transplant donor and recipient data. And then we have all the outcomes of each transplant recipient too. So we have some follow-up for them too. And ultimately what we have, the result is this high fidelity database of time series format anesthesia data, and then a comprehensive transplant data and outcomes database for about 600 or so, over 600 kidney transplant donors and patients. So quite an interesting and unique data set. Between 2010 and 2022, we got data on 609 records with both the static pre-transplant data and the dynamic time series data. And then we fed that into two main pathways of analysis, what we call a classical pathway and then also a machine learning pathway. So we'll talk about the classic analysis first. Our first aim was to simply take all the time series data that we had and then graph it to get a sense of the typical patterns of blood pressure variation at different time points throughout the surgery. And then we split these graphs between DCD kidneys, donation after circulatory death, NDD kidneys, neurologically determined death, and then LD or live donor recipients. And then these graphs, what we see is what we've plotted here is the average mean arterial pressure in kidneys with DGF. That's the solid line. And then without DGF, that's the dotted line. And then this was averaged between each of the recipients within the sub-cohort. And then lastly, this gray box over here that you'll see, it represents the average start and the average end time of vascular anastomosis for the transplant operation. So it's possible to also infer changes in hemodynamics around that specific important event. As a note, while we're here, over the rest of the presentation, you'll hear our discussion often center around blood pressures at or after the time of anastomosis. We believe that that's the most important period intraoperatively for the newly transplanted kidney because it's kind of the first blood flow that the new kidney sees. It also represents a time point in the operation which allows for optimization work to be done in a paced and controlled manner. So to actually get some insights from what we're looking at here, with this approach of directly graphing the average blood pressure courses, we note some interesting trends between surgeries that result in DGF and then surgeries that don't. So in live donor recipients tend to start out at roughly the same blood pressure, but then nearing the average time of anastomosis and afterwards, the blood pressures tend to be substantially lower. And then this eventually resolves sometime after anastomosis ends, but by then there's a good chance that the damage has already been done, so to speak. On the other side, in DCD recipients, on average, blood pressures are consistently lower in those with DGF than those without throughout their entire operation. And that suggests that blood pressures could be a modifiable factor in the incidence of DGF. And then finally, in the NDD recipients, there does appear to be some difference in the map between those who do and don't end up having DGF, but that's less than the map difference in DCDs. Of course, all of this data is retrospective, so the observations we make here and then mostly afterward as well are hypothesis generating more than anything. And then also it should be noted that the incidence of DGF in our live donor cohort is quite small, only 3-4%. In any event, it still appears that the maintenance of adequate map throughout the case is probably a very important determinant of early outcome in these, even in these higher quality kidneys that have a greater physiologic reserve going in. We also performed a similar analysis looking at the use of IV crystalloids administered throughout the surgery, and that's expressed in cc's per kilogram per hour on the y-axis instead of MAP. And we can continue to make some interesting observations. In live donor recipients, those who ended up getting DGF, they received substantially greater infusion rates of fluids, a fair bit prior to anastomosis. And then the MAP dip that we observed in live donor recipients happened at anastomosis. So it seems like maybe the increase in fluids kind of occurred prior to the MAP dips in the small subgroup of LD recipients with DGF. And then in DCDs and NDDs, it looks like the crystalloid infusion rates are roughly similar. And maybe that suggests that despite the blood pressure differences between the two groups that we were seeing, there might have been a bit of an inadequate response to fluid replete those patients on the table who ended up having DGF. Our next analysis was to characterize DGF incidence across multiple intervals of post-anastomosis hypotension. So on the y-axis, on the x-axis, what we're seeing is certain buckets of mean arterial pressure post-vascular anastomosis. And then on the y-axis, we have the proportion of patients in that bucket that experience DGF. And then in the corner, what we have is a concordance index. It's kind of like a discriminative score, like an AUROC for the x-axis to predict the y-axis. And for reference of 0.77 is pretty good. Taking a look at the data, what we see is that the incidence of DGF in DCDs, that's the triangles, it's quite similar to NDDs in squares when the MAP is at or above 85. But then after dropping below 85, there's a sudden doubling of the incidence of DGF from about less than 25% to just under 50%. And then for every subsequent decrease in post-anastomosis MAP, the incidence of DGF just rises higher and higher and higher. In NDDs and live donor recipients, those folks are less susceptible to hypotension, and the incidence of DGF only marginally increases in recipients with those donor sources. So that's good. And then what we're looking at here now is we're taking a look at, we can also examine the blood pressures in transplant in the context of the kidney donor's preoperative baseline blood pressure, whether that's a living or deceased donor. And we can also take a look at the blood pressures post-anastomosis as a percentage of the recipient's baseline blood pressure. So we're not just expressing the blood pressures in terms of absolutes, but as a percentage or relative to the patient's baselines. And we see similar patterns of hypotension susceptibility in that the DCDs are more susceptible to DGF than the NDDs and the live donors. And then also what we see is that even using these relative measures of hypotension, the concordance indexes of these measures is pretty equal to, if not maybe slightly worse than just using the absolute MAP. So overall, what we're trying to suggest here is that there's some concordance and there's some relevance of using relative or patient personalized blood pressures to predict the incidence of DGF. Now, because we have this time series data over the entire operation, we're able to extract what are some pretty interesting features that actually relate more to the attending anesthesiologist decision-making than anything. So what we looked at here was something that we call mean MAP triggering pressor use. We looked at what the MAP was when an anesthesiologist decided to start an infusion or give a bolus of a vasopressor. And so that kind of reflects the anesthesiologist decision making. And we see some similar trends. As expected, what we see is that the people who didn't need any vasopressor at all, this NA group here, generally did the best because those patients weren't vasoplegic. They didn't require an intervention. And then what we see is that if the anesthesiologist waits a little bit too late, especially in DCDs, after the MAP falls below 65, then that person tends to do worse, or those people in that bucket tend to do worse. But for starting pressors at a fairly wide range of mean arterial pressures post-anastomosis, all of these folks tend to do roughly similarly in terms of DGF incidence. So we'll hang on to that. We felt like it was an interesting variable to extract, so we'll be coming back to that one actually. Now, we recognize that DGF, while it's still a patient-relevant outcome, it is a bit of a surrogate. We wanted to look at long-term outcomes as well, and we did have some of that data. On the left side, what we have are serial creatinines 1 to 60 days post-transplant, and then we compared that in DCDs and NDDs, and then we compared that between people who had a MAP above 75 and then a MAP below 75 post-anastomosis. And then what we did was we also looked at the first 1 to 7 days post-transplant, the differences between the two groups, and then the 14 to 60 days post-transplant. And we detected that there was a difference in serial creatinine drop-off in DCD kidney recipients just within the first 7 days. But then this didn't actually persist by 14 to 60 days post-op. And then in NDDs, there's no difference whether you're at 1 to 7 days or 14 to 60 days. The rates of creatinine drop-off are pretty equivocal between the two groups. And then on the right, we have 5-year graft survival. And what we see is that there's no major difference in graft survival between the two groups, at least in our cohort of 600 or so patients. For visibility in space, I didn't include the data on the live donor recipients, but we did have it. They also didn't, they were kind of similar to the NDDs. They didn't demonstrate any divergence in either serial creatinine or in 5-year graft survival. Now, one struggle that we have with discussing these topics is that all the variables are highly intercorrelated. So to get a sense of how the important variables are interrelated, our last classic analysis before we start talking about the ML stuff is a graphed logistic regression curve of the average MAP versus DGF incidence. And then what we've done is we've added an interaction term to see how the risk curve changes when you look at people who receive different doses of pressors during the case. We picked phenylephrine here because it was the most commonly recorded pressor that was used in our patients. And what I want to draw your attention to is the intersection of these different interaction risk curves. Overall, what the graph is suggesting is that there may be a bit of a sweet spot for pressor use. So black here is the baseline risk curve where a mean quantity of pressors is used, about 400 micrograms of phenylephrine. And then the orange, the colored line, is when a high dose of pressors is used. That's a mean plus 1 standard deviation's worth of phenylephrine, approximately 1,300 micrograms. And then gray line is when no pressors were used. And the trend we observed is that if high doses of pressors are used when the MAP is below 75, then the DGF rate in orange is lower from the baseline in black. And that makes sense because responding to the hypotension is good. But if your MAP is above 75, if the patient is maintaining the MAP above 75 and more pressors are used, if, in other words, if the pressors are used too liberally or too early, then the pressors may actually increase the DGF rates from baseline. So we can generate this hypothesis that high MAPs might be better overall because the overall trend of all of these curves is tending to go down. But using increased doses of pressors for achieving that artificially past a MAP of 75 might actually be detrimental. And it's the same intersection whether you're in DCDs or NDDs. The same pattern persists. We did a similar analysis, except this time with cumulative IV fluids. The black, again, is the baseline. That's about 2,500 cc, so 2.5 liters of crystalloid. It was either normal saline or some kind of balanced solution like Ringer's or more often Plasma-Lytes. And then the colored line is mean plus 1 standard deviation. So that's 3.5 liters. Mean minus 1 standard deviation is 1.5 liters. And we're seeing a similar effect where there's, again, an intersection at exactly the same place at 75 millimeters mercury. Using more fluids when your volume is lower is good. And then using more fluids when your blood pressure is higher than this is not as good. Now, the use of an interaction terms regression is kind of just the start in our attempt to tease apart very complex relationships in our data. So this is where we start to think about a machine learning approach. Anesthesia data sets are very, very large, and there's many complex relationships between the variables, especially in time series data. And this is a situation where ML, we felt, could perform really well compared to conventional analysis. To illustrate the point, I want to showcase a bit of a toy problem. Here we have this Cartesian coordinate grid with points. In the top left and in the bottom right, you have all the yellow points. And in the top right and the bottom left, you have all the blue points. And it's a pretty simple relationship between the data, but it's not linear, right? So if you try to fit a linear model, like a linear regression to split the data evenly, it obviously fails. It misses all the blue points in the bottom left. But if you apply even a very rudimentary neural network with not all that many neurons in it, it's able to recognize the nonlinear relationship and delineate the points perfectly. And so that's kind of the advantage of ML in a nutshell. And then the other interesting thing is that ML can also explain how it got to those predictions. So more on that in a second. So again, we've collected this wealth of data that's suitable for ML analysis, and our prepared data, after we extracted what we felt were relevant features from the time series data, by generating a bunch of different features. We generated like 180 plus features on 609 patients, as I mentioned earlier. What we did was we ran this strategy that kind of ranked the features by importance, culling it down, the 180 features down to about 20, 25 features. And then we kind of looked at what we felt was most important within those features, what was most like human, like actually actionable surgically. And we managed to cull that down using a combination of automatic ML selection and then also human selection. So using domain knowledge-based techniques. So we culled that down to about 12 features, and then we fed that into our particular ML model. It's a gradient boosted tree model. So feel free to ask any questions after if you're interested in like the specifics. And then we were able to, one, characterize the accuracy of the model, but then two, also undertake a bunch of what so-called SHAP explanatory analyses. So let's talk about the accuracy first. We tested it on a holdout portion of the original data set. And the overall accuracy is pretty good. It's a little under 70% with a sensitivity of 91%. And here we have an area under the ROC curve of the CAT boost model of 0.75. So it's not bad. And when we take out all the features that are based more so on pre-transplant data, like the recipient's age and sex, and whether it's a DCD kidney or an NDD kidney, and we only look at the anesthesia data, only look at the time series data, we see that even when you take out things that really, really contribute to DGF, like whether it's a DCD kidney versus a live donor kidney, what we see is that just the anesthesia data alone in red, the only time series features data, still has good predictive value with an area under the receiver operating curve of 0.67. So there's some predictive value to just the anesthesia data alone, even independent of all the other big predictors of DGF. But now that we have this baseline predictive value of the model, what we're particularly interested in is how the model arrived at its conclusions, because that's what tells us how we should suggest that anesthesia should be different. And that's where the SHAP explanatory analysis comes in. So what you're looking at here is called a B-swarm plot. It's quite information dense. If I had to summarize it in one sentence, it's a plot that represents the value of each variable in making the predictions of the overall model. And then it also represents how different values of the variable itself influence the final prediction. There's three things to understand in order to interpret the plot. One, each row that you're looking at is a different variable that's included in the final model. And then the variables are ordered from top to bottom based on the most important variable to the model to the least important variable. And then each dot you look at represents a patient that the model is making a prediction for. Red means that the patient had a high value of that variable. So this person had a high cold ischemia time. Blue means that this person had a low cold ischemia time. For binary variables, this person had like live donor equals 0, so they did not have a live donor kidney. This person did have a live donor kidney. All of these people did. And finally, the further a dot is to the right, with a +1 SHAP value, the more likely that model is to predict that person would have DGF, and then vice versa, the further a dot is to the left, with a -1 SHAP value, the more likely it is that the model will predict that they don't have DGF. So for example, if you're an NDD recipient kidney in red, the model thinks that you're less likely to have DGF than someone who received a DCD kidney. And so at the top of this plot, we have cold ischemia time, which of course contributes to DGF incidence. That makes sense. And live donor just below it, that also makes a lot of sense. What we see that the model ranked really highly though was post-anastomosis map. So that's something that's intraoperative and it's controllable. We can give pressors, we can give fluids, we can do things to change that. And so that's really, really interesting to us. And then if we go down a couple more, we see that there's total IV crystalloid infusion. And then total phenylephrine as well. And these things are also really important to us. So it seems that higher infusion rates are associated with DGF incidence. And then you'll also notice that some of the purple stuff is in the middle, that like low infusion rates also did the same. And then all the moderate values are in the middle here. And so that's kind of worth looking into. So there's a bit of like, it's not just totally linear where things make a lot of sense. Like with cold ischemia, high cold ischemia is bad, and then blue, low cold ischemia is good. Looks like there's some heterogeneity in the colors. So we'll look into that, what we call dependence plots. Overall, though, the takeaway from this is that there's a bunch of operatively actionable parameters here that rank highly for contribution to DGF incidence. So to interrogate the model more, what we do is we can build these so-called dependency plots. Again, high SHAP values means that the model thought that the patient would be more likely to have the outcome, and low means that the model thought they'd be less likely to have the outcome. And what we see here is when we look at a dependence plot for the post-anastomosis map to DGF incidence, there's a sigmoid relationship where a post-anastomosis map of 90 or greater is associated with the lowest amount of DGF, and then a post-anastomosis map of 70 or lower is associated with higher DGF. And what we can do is we can also segregate each of these patients into checking, oh, did they have an NDD kidney or a DCD kidney? And from there, what we can do is see if both of those different subgroups have different requirements for the map. What we found is that, generally speaking, both of them seem to benefit from having higher maps. Now, if you remember, I was talking about how there was that color variation or that weird like heterogeneity, that non-linearity in the BSORM plot for IV fluids. And now we can build a dependence plot to look at what caused that. And what we're seeing is that instead of a sigmoid curve or a line, you see this U-shaped curve. So what the U-shape is telling us is that moderate infusion rates are best because they have the lowest SHAP values. If you have a high infusion rate, here, like 40 cc's per kilogram or greater, those people tended to do worse. And then if you have an excessively low infusion rate, those people also tended to do worse. The next variable we wanted to take a look at was the pressors and the pressors, in this case, phenylephrine still, and DGF incidence. And what we see again is a bit of a U-shaped curve, but it's different. So this time the U-shape is in the opposite direction. And first, let's take our attention and just look at some of these blue dots here. So what you're looking at is from 0 to 10 micrograms per kilogram of phenylephrine given. A large number of these people got only boluses of pressors, so no infusions. And if you're looking at someone in red, that person got an infusion of a pressor. So we're seeing is that if you got a bolus, if the more boluses you needed, like presumably like the worse you did, your SHAP value is higher. And again, that makes sense because as I was saying earlier, if you don't need a bolus, you're not vasoplegic, you're probably doing fine in the OR. So that makes a lot of sense. But it was a bit of an interesting pattern, seeing that if you were getting an infusion, you could get pretty high doses of pressors, from like 10, 20, 30, 40 micrograms per kilogram in total over the course of the operation. And your SHAP values for those folks weren't all that high. So the model thought that using an infusion seemed to be at least safer for preventing DGF than just giving intermittent boluses. So that was an interesting finding. And then coming back to that variable I was talking about, threshold to start pressor and DGF, again, we see this U-shaped curve where, if you have a threshold to start your pressor around 70, those patients, the models seem to think that the patient would do better. And if you gave pressors at excessively high ranges, or if you waited too long before giving a pressor, your DGF rate would kind of go up a bit more. And again, we're segregating this by whether somebody had an NDD donor kidney or DCD donor kidney. And we're seeing that the patterns are about the same between the two subgroups. Now, while that analysis strategy was pretty powerful, ultimately what we realized was that we were taking the most powerful aspect of our data, which was the time series component, the continuous component, and then we were compressing it into a tabular format. So we were summarizing it into a table and then analyzing that. So what we wondered was, what if we could directly analyze the time series as actual time series? So what we did was we used this time series, multivariate time series analysis architecture that someone else published called XEM. And then we fed in the actual time courses of the intraoperative vital signs. And then we saw what the model thought was the most important part of the operation in terms of thinking like, well, would this person have DGF or would this person not have DGF? For example, would it happen, like, is the important part of the operation before anastomosis, during anastomosis, after anastomosis, that kind of thing. So what we've got, and this is early stages so far, is that, so this arm or analysis is still a work in progress, but the initial analysis is promising in its face validity. We note that the post-anastomosis blood pressures after this gray box appear to be doing most of the prediction. They have the highest importance in red for predicting the incidence of DGF. This is a similar graph to what we were seeing in the very first graphs that we were looking at. But now the model, the XEM architecture has labeled for us with this heat map of like which part of this surgery helped it predict DGF. So pretty interesting stuff. And we're also seeing that some of the high blood pressures that are around induction also have some predictive value for predicting DGF. My personal thinking about that is that it's basically a representation of someone's preoperative blood pressure, and you know, moving forward, once they're out of PACU, their preoperative blood pressure may also have an influence on their postoperative graft function. So that's my thinking as to why these early dots are also red. And then finally, what we also did was we took the CAT boost model, the gradient boosted tree models, using the tabular data ML. And what we were able to do is create a preliminary work in progress web app that basically takes a bunch of input information about the recipient and the donor and the kidney, like the age, sex, BMI, their baseline map, the donor's baseline map, cold ischemia time, whether they had a DCD kidney or not. And then it spits out a bunch of recommended anesthesia targets. So that's kind of like the grail, right? So we have all this data, even if it is retrospective, and we want to use it to make like good targets that we can then test in prospective trials moving forward. So yeah, to wrap up, some key messages that we want to impart are that intraoperative blood pressures are important. Pressor use is important. IV fluids are important to the incidence of DGF, and they're really tied to each other and they're interrelated in a very complex way. So hopefully by undertaking analyses that respect those intercorrelations, either with or without machine learning approaches, we're hoping to structure future decision-making in manipulating physiologic targets and hopefully move closer to maximizing the benefit of every kidney donation and moving towards that one transplant for life goal. So yeah, that's about it. Any questions?
You're on mute, Cynthia.
Exactly right. Thank you very much, Doctor, for that excellent presentation. That was very informative and insightful. I will open the floor now to any questions, concerns, and additions. Questions, concerns? We have 15 minutes to end this session.
Hi, Rohit, I have a question. First, congratulations.
Yeah.
That's an absolute ton of work getting all that paper chart into electronic systems. I've done a few projects like that, but not 600. Amazing. I was just, like, so when I was looking at your kind of your input variables, your living donation, NDD, DCD, did you look at shipped versus locally procured kidneys, or is cold ischemia your kind of your predictor there? And then also, did you look at use of perfusion pumps versus cold storage in terms of the resulting DGF or IV fluid use or MAP or your other kind of perioperative indicators?
For the first question, no. Yeah, we're just using CIT as the surrogate for whether something was procured. I don't have the data on whether it was procured locally or not. And then as for whether like normothermic machine perfusion versus just static pump storage was used, I wish I had that data. We do have it. We do have it.
Yeah,
I haven't transcribed it, so that's on me.
yeah.
Will we have that data? So it's something we're kind of working on.
No, it's really cool. I just know when the pandemic hit and the national kidney programs, especially paired donation, moved their living donors to almost entirely shipped kidneys, where they used to ship the donors. A big assumption was that the overall impact was not going to be that huge. But you seem to have an ideal data set for helping to augment that argument, or maybe bring some additional questions to the fore.
For sure.
Cool. Great job.
Thank you.
Hi, Dr. Malyala. Yeah, so probably I'll just take this opportunity while others warm up to ask a question. I'm just curious in terms of did you encounter like complications with this procedure in relation to kidney transplant? And if there have been records of complications with this procedure, what has been the percentage of like unsuccessful procedures or something like that?
Your voice kind of cut out there. So what I heard the question was, how often do we encounter complications in kidney transplant? The vast majority of our transplants are
something like that, and especially with this, with this procedure.
Yeah, the vast majority of kidney transplants, even intraoperatively, are technically successful. Like the anastomosis goes fine, and everything is fine, and the patient tolerates the procedure really, really well. And there's no real intraoperative blood loss. I can like count on one hand out of 600 people how many people like actually had a failed surgery. So it was very minimal. But the incidence of DGF, of course, varies based on the kind of, which is a kind of complication, right? It doesn't necessarily relate to the surgical technique, but it is a complication. And the incidence of DGF varies based on the donor subgroup. So live donors, we had a 3% DGF rate, which makes sense because those are like the highest quality kidney. And, they have like almost no warm or cold ischemia time. NDDs are a percentage overall. Was about 20% DGF, and then DCD kidneys was somewhere in the range of 40 to 50% DGF rate. So that's our like major postoperative complication. And again, it doesn't really relate to the technical factors of the surgery as much as, outside of the research I'm literally presenting right now, which is about anesthesia factors. But it probably has also a lot to do with the just where the kidney comes from.
That's true. We still have about 10 minutes to end the session. So if we have any more questions for Doctor.
So,
sure.
I mean, if no one else is jumping in, I've got all sorts of curiosities. But now, if you entered this into your new Cerner patient record management system, does that now mean that you have far more additional data from kidney clinics and from pre-transplant workup and all those kinds of things going forward? Like, I don't know how much historical data got into the Cerner system, but like is your capabilities in machine learning and things like that going to be greatly enhanced now that it's all under hopefully one system, or is outpatient clinics and things like that still in some other world?
Yeah, it's still challenging to integrate all these different data sources, and we thought that getting Cerner on board would be a little bit easier than it is, and we're still talking to a bunch of anesthesiologists, and it's not anesthesia's fault. It's about CST, and it's a little bit tough to try to get them integrated into and getting the data in a easily analyzed fashion. So we're still in talks with folks about how to do that.
Yeah, so we here in Alberta, we went to the Epic system, but province-wide, every hospital, every ER, every everything, and I've yet to see that exact benefit myself. So I want to see it work for all the money and effort going into these systems.
Right? That's the grail for like every researcher. You have all this data. It's not in like an easily analyzed like form, and it's just like there in front of you. You work with it every day, and there's nothing you can do about it. So it feels bad sometimes, but that's the nature of it.
And I'd be remiss, just because I'm also a 2-time transplant recipient. I may work in an institute, but I'm also a recipient. But do you have requirements in your project for patient partnerships or family involvement or things like that? Because you're kind of, you know, that one step away from the patient clinic side when you're in anesthesia. But do you have to include patient partnerships and things in your studies, and especially funding proposals and things like that?
Yeah. Recently, we got the CDTRP venture grant approved. And so, yeah, we have 2 PFDs currently, both transplant, one donor and one recipient, Mr. Scully White, and then Miss Teresa, I don't know, I forgot.
Atkinson?
Yes.
Atkinson.
It's Atkinson, yes.
I know Teresa well from Kelowna.
Yeah. And so we haven't scheduled any meetings yet because we just got approved a little while ago. And so I still have to like get the ball rolling on that front. But we have 2 PFDs on board.
Oh, fantastic. I'm in a critical care trial as a patient partner, and similarly, it's a lot about the decision making ahead of any kind of procedures are done, and the intent is to head off people going on to dialysis, which is so it was always a bit of a stretch when they first started it, but we've kind of found our stride with after a few meetings. Oh yeah, no, we can get on board. I mean, but I think the patients and families definitely help to define where they can see themselves playing a part in some of those studies too.
And I think what we're really curious about is, in particular, is moving forward. Again, part of like what our eventual goals are to involve ML in patient care, and how do patients actually feel about something like that? And that's, I think, something that we're really curious about, even if it's not specifically related to this work, like even just broadly, AI and ML, like even if it's just something as simple as suggesting to an anesthesiologist, you should use this blood pressure. Like, how does somebody feel that this ML model came up with that?
Right. Yeah, for sure. Thank you.
I saw another hand for somewhere, I think. I'm not sure.
Yeah, I think it was
clapping for the for the venture grant because this is great.
Exactly
we are
right.
very excited about this project. Yes, thank you.
Yeah, congratulations on securing that grant. I think I see that time is just about up, so I would just probably roll out from here. Thank you all for today's session, for the comments and questions throughout today's presentation. And Dr. Malyala, on behalf of CDTRP, we say thank you very much for this wonderful and excellent presentation. And if anyone has additional comments, questions, or suggested topic and speakers, you can kindly contact Erica at ekcroft@cdtrp.ca. I think the email address is actually on the chat box, so we can copy it and then get in touch with her. On that note, I say thanks to everyone, and especially to our presenter for today's session. And I wish everyone a beautiful afternoon. Enjoy the rest of the day. Thank you.
Thanks, everybody. Thanks, Cynthia.
Thanks, everyone, for having me.
All right.